All right, hello again. In this lecture, we're going to be diving into a little bit more about radiography and what your responsibility will be as a rad tech. So, I'm going to start right in. Radiologic technologist, what you'll be doing is a person who's going to administer that radiation to perform radiographic procedures, usually of diagnostic quality, in order to tell the radiologist who will be reading the imaging what is going on with the patient. So it should be providing some information. So you'll be producing those images at the request of a licensed medical practitioner. That could be a pretty big variety of people. Chiropractors can send orders for imaging, medical doctors, physical therapists, a lot of different variety that you could be getting, depending on where you'll be practicing at, in a hospital setting or at an imaging center. So in order to produce these images, you will be interacting with patients using your technical skills, your knowledge of anatomy, physiology, and pathology, and kind of applying that. So you'll then evaluate the images to make sure that they are of good technical quality, that they're accurate and appropriate and relative to the diagnosis or procedure. For example, if a patient is getting imaging for a kidney stone, they shouldn't be coming in for a neck x-ray. You should also be using your critical thinking and professional judgment. If you think something isn't appropriate or maybe the doctor forgot to add something on, you can always reach out to them and see and clarify if that is exactly what they meant. One of the main codes that you will kind of abide by as a rad tech is ALARA, using each exposure as low as reasonably achievable. So that means that you're going to be making sure to the best of your ability that every time you take an x-ray, you're exposing the patient to the least amount of radiation that's reasonably achievable to get the imaging that you need to be of diagnostic quality. So with patient care, you'll be communicating with patients, assessing them, monitoring them, supporting them, which may be physical, emotional, depending on the amount of kind of trauma they're going through that day. If you're working in a hospital setting, this is a patient that came in through the ER versus somebody that just walked into an imaging center. It'll be a lot different depending on where you end up practicing. You'll take a patient history prior to your exam. You'll explain the procedure in as much detail as you can, especially for those who have never gotten an x-ray, or sometimes you'll have kids that are getting x-rays done, and you'll have to explain to them what you're doing and that it's not going to hurt or and all of that good stuff. You'll be assessing and monitoring the patient's well-being, especially if they are in a traumatic setting. They're just coming from a car accident or a fall or something along those lines, to make sure that they are still doing well throughout the entirety of the procedure. Your radiography practice standards will be kind of watched over by the ASRT, American Society of Radiologic Technologists. You'll be looking at your scope of practice to see what the definition is per state. You'll look at clinical performance standards, professional performance standards, and you'll have your education and certification to kind of back up your decision making. The health professional's moral responsibility and the science of appropriate conduct toward others is really important, that you're performing everything to the best of your ability and maintaining your standard of ethics. Again, this is along the lines of making sure that you are looking at ALARA and making sure that everything that you're doing is appropriate, even if the doctor may have ordered something different, that you're reaching out to that provider to make sure that it is exactly what the patient needs. Caring for the radiologic room is also important, and will be your responsibility. So making sure that the surfaces are cleaned with the approved cleaning substances or wipes, depending on your area of practice, changing linens on beds. The tabletop and other patient surfaces should be cleaned after each patient, especially if there's bodily fluids, bleeding, discharge. You'll make sure that those are cleaned off, but between every patient, they should be cleaned. Before the patient arrives, it should already be clean and organized if they're entering an environment that is a little less stress-free. A little more stress-free, rather. The standard precautions we'll be using are based on the CDC, the Centers for Disease Control. They're pretty straightforward, making sure that you're using hand hygiene before you put on PPE. Sometimes when a patient comes in, they're bleeding or there's some other bodily fluid, you want to make sure that you're using personal protective equipment like gloves, sometimes face shields depending on what's going on. That you're using respiratory hygiene, aka cough into your elbow or sneeze into your elbow. You're handling, clean, and disinfect the patient care equipment and environment. You're following safe injection practices if you're going to get into interventional radiology. If there are any sharps, that you're handling those properly and disposing of them in sharp containers. And being aware of transmission-based precautions for known or suspected infections like tuberculosis or MRSA type staph infections. So we're going to go through the basic patient encounter and kind of how the flow of that would work. So first you would introduce yourself, you'll explain the procedure, allow for questions, and then be honest. Patients will cooperate more favorably if they know what to expect. Sometimes if they're coming in for a fracture, there's certain positions that they'll have to be in to be imaged that aren't going to be super comfortable. And so if you let them know that ahead of time, they'll appreciate that and know that you're not just doing your job improperly, but that it's just something that's necessary for the imaging. So an example of this would be, hi, I'm Dr. Beck. I'm going to be performing a cervical x-ray on you today. What we'll do is we're going to put you in front of this x-ray unit. We're going to take a couple of pictures, and when we're done, we'll be able to send those off to the radiologist for interpretation. I won't be able to give you any of the results today, since I am a radiologic technologist. That'll be out of my scope of practice. But if you have any questions, if anything's uncomfortable, please let me know. Do you have any questions for me? And then they could ask questions. There will be some considerations depending on the patient. So in older patients, you might want to make sure that they are stable, depending on whatever x-ray that you're doing. Sometimes for a setup, they're required to stand in a way that might make them feel a little wobbly, or depending on a patient's special needs, kind of similar things. So making sure that you have something within the actual room that they can hold on to, or something along those lines, or if it's something that you can modify into a seated position so that they feel a little bit more comfortable, then that can be done as well. Kind of similar to that with injury or illness, and we already kind of talked about patients who are younger and how you might explain what an x-ray is and what they should expect. And we'll talk about patients who are immobile kind of later in the semester. But there are a million ways to do different types of x-rays. Some of these that we'll be learning, like the chest x-rays, you'll be doing a lot in patients that are, if you're working in a hospital setting, that are coming in through the emergency room, and you might not be able to do a perfect P to A chest x-ray with inspiration because they're coming in shortness of breath and not exactly in the best mental state because of that. So there are different ways that we can modify our procedures to still get the best diagnostic quality possible, but also keep those patient considerations in the back of your head. When you do have a trauma patient, it's really important that you are careful, especially with moving them. So if somebody has a suspected skull or spine fracture, you'll generally see that in the history or in the order that you get. You'll want to make sure that you're moving them as little as possible to get that imaging, because that could severely injure them. Long bone fractures are the same way. So if you suspect a femur's fractured, you don't want to start kind of torquing their body to put them in the correct position. Sometimes, a true A to P or lateral or whatever type of imaging procedure you're trying to do is not possible. So you'll have to do the best with what you've got, essentially. So in that way, like I said, you'll have to adapt your positioning. If you do have to lift or move a patient, make sure that you're not doing it alone, especially if they're much larger than you. You definitely don't want to hurt yourself and be out of work. When you are moving a patient, you'll want to make sure you're supporting their head and shoulders and using moving devices correctly. Later in the semester, we'll talk a little bit more about how to do that as well. So after you've greeted your patient, you kind of explain what you're going to do today, you'll want to make sure that the patient tells you what their name is, and you use 2 identifiers or whatever protocol your working location has. Sometimes it's more than that, sometimes it's less than that. So you want them to tell you their full name and date of birth. You'll check that with their name bracelet if they're in the hospital setting. Maintaining HIPAA the entire time, obviously. You're not disclosing that patient information to other people or leaving it accessible to others. In the healthcare setting, if you're working in a hospital, that includes leaving your computer open for others to be able to view that patient information. Or like on a sign-in sheet, sometimes patients have to sign in to different imaging locations. Leaving that name and patient information accessible to others can be a HIPAA violation. So what isn't a HIPAA violation is if you were to talk to another provider or somebody else about a case that you saw today. As long as you don't use any identifying information, that's absolutely not violating HIPAA. You could say, I had an older lady today that came in with a hip fracture. It was crazy. That's totally fine, as long as you don't say Mary came in with a hip fracture. She was 86 and this was her date of birth. When you take a clinical history, again, we're looking at the exam that was ordered, and is it consistent with the reason for the exam today? You'll obtain a relevant clinical history and observe for any apparent abnormality that may affect the image. Sometimes patients will have congenital conditions and they, again, won't be able to be set up in that perfect A to P, P to A lateral image. So if that is the case, that's just something that could be documented for the reading radiologist. The radiologist is not going to see the patient, so it's up to you to present the information that may affect the diagnosis. So if somebody has a specific abnormality that doesn't allow them to be set up in that perfect A to P, that's something that you'll have to make sure that you tell the patient or the radiologist so that they're aware. Interpretation of the images is out of your scope of practice as a radiographer, so this is something that will come up a lot and is important to kind of get a script down for, because patients want to know what you think based on your expertise, your schooling. If you see a fracture, you have to kind of school your face and make sure that you've got your poker face on, because it's out of your scope of practice to tell them what's going on in that imaging, even if you see something that's blatantly obvious. So that will be up to the job of the radiographer, and you can tell them, depending on the practice that you're working at or the hospital that you're working at, what the usual turnaround is for getting results for that. If you see something on the imaging, however, that is serious or life-threatening, then that's an immediate phone call. So if you're working nearby them, then you can stop by their office, but if you're in a separate area of a hospital or something along those lines, it's important to notify them as soon as possible that there is something serious or life-threatening that may be on that image. Not the patient, though, because again, that is outside of your scope of practice, but this will kind of prioritize that imaging so that the radiologist can look at it faster. To prepare the patient for imaging, you'll have them change into a gown when necessary, especially for something like chest imaging, where women will be taking off undergarments, bras that have underwire. Oftentimes they'll want to have a gown on for situations like that. You want to make sure the patient remains covered and not expose unnecessarily. If you have to move it for certain parts of the procedure or to see the light behind them to know that you're setting them up appropriately, that you move it just for that time period and then put it back where it was so that they're not exposed unnecessarily. You want to make sure that if they have any jewelry on, any metal at all that will show up as really white or radiopaque on the image, that they remove those from the areas of exam. If they have earrings on and you're taking an image of their abdomen, it doesn't matter. Anything within the light that you see when you're setting up the imaging has to be removed as far as jewelry and metal are concerned, including things like keys and pockets or belts if they have metal belt loops. Sometimes you'll be taking imaging of the pelvis, and that would be an example of someone that might need to be in a gown, especially if they come in and they have metal zippers or grommets on their pockets, things like that. We've also before seen imaging where people had bedazzled underwear, and so they had to have that removed before they took the imaging because it all shows up on the x-ray. Some exams, especially with some interventional procedures or some that require contrast, will require special diet or pre-med prep. So depending on the setting that you're working in, that might be something that you have to administer or prep the patient on. Prior to exposure, sometimes you'll do breath instructions. So especially with chest imaging, you'll have them take in a breath and hold it. However, with inspirations and expirations, they almost never do a good breath the first time. So I usually say take a deep breath in, out, take a deep breath in again, hold that. With expiration, same thing but opposite. And why do we do this? If we're taking imaging where we can see their diaphragms or they're breathing during a longer exposure, they can start to blur certain anatomy. When we're doing chest imaging, we want them to take a nice deep breath in and hold it during inspiration, because as they breathe in, the diaphragm's lower, so we can actually see more of the chest. If it were the opposite, expiration, sometimes we'll see that with abdominal imaging, because they will have a higher diaphragm, we'll be able to see a little bit more of the abdomen. Sometimes we'll want those for specific chest imaging if we're looking for something a little bit more subtle. You've heard me reference the image receptor a lot, the IR. So that's the thing that's going to be receiving the energy of the X-ray beam and forming the image. There are a lot of different types. The one we'll be working on in lab is a digital one, so DR. That means that as soon as the X-rays hit that panel, it'll start converting it straight to the computer. So this is the most expensive type of unit, a digital unit. So it's a pretty fun one to practice on. But the ones that you'll be working on for practice in the other labs, so that you have practice with different types of units, is more of a cassette with a film. In this case, the cassette kind of acts as that digital detector, like an imaging plate. However, it has actual film inside, and then you put it into a unit that kind of reads that film and then converts that into a more digital format. So imaging receptors can be multiple different sizes. You have inches and centimeters here. So 8 by 10, 10 by 12, and 14 by 17 are the most common that we'll use. In the in the lab, when I show you the setups and whatnot, there'll be the 14 by 17. It's a little bit larger. However, when you practice, you can use all three of these. They're in the practice lab, different types of cassettes. So if you have a smaller body part, you might want to use a smaller cassette. In reality, in those types of things, they would use less film and be less expensive to hospitals. It doesn't really matter as far as exposure is concerned, because as long as you collimate well kind of crop in that light, we're exposing your patient to less of that X-ray radiation. So we've talked about prepping the room, gathering equipment. We've talked about choosing the imaging receptor. We've talked about identifying the patient and explaining the procedure and obtaining your history, prepping the patient with gowning. So now we're going to talk about the rest of this. So you'll put in your technical factors into the computer. Generally, we'll see these in terms of MA or MAS, milliamperage, kilovolt peak, kVp. I can tell you right now, most people just use MAS and kVp, and sometimes exposure time. So it allows us to kind of control the amount of contrast that we're going to be using on the patient and the timing of the exposure. We might want a longer exposure for thicker body parts and things like that to allow the X-ray to actually travel through. But you'll learn a little bit more about these when you get into your more physics-based classes. Luckily, you won't have to memorize the MAS and kVp that you'll need for each setup. In every room that you'll be in, you should have an exposure or technique chart. And basically, you measure the patient's body part. You'll look at the chart and it tells you exactly what to put in the machine. So it's really helpful in that way. So that'll just be for an average size adult or depending on the patient's part thickness due to the measurement. Some factors will be adjusted based on the patient. Sometimes you'll use machines that you'll just type in, you'll click that it's a chest, you'll click that it's an average size patient, and it already has your MAS and kVp in the machine. I think it's a little bit more accurate if you are able to measure it and input that information yourself, because sometimes the machine is just not calibrated enough, and your version of average size might be different from someone else's. I'm sure you've noticed that when you've looked at X-rays, they aren't in color, they're in grayscale. So we have all these different shades of gray, 5 main ones. So looking at the shades of gray can help us determine what tissue is made of, and it's based off of how easy it is for X-rays to penetrate that tissue. So this is delving a little into that physics, but it is important to note because there is some terminology that we use, radiolucent and radiopaque a lot, that'll be important for you to understand kind of what we're talking about. So I said that something that's radiopaque is more bright, more white colored. So things like metal, things like bone are more radiopaque than things like air and fat. Something that's more radiolucent is more dark, so it's more on that darker side of the grayscale. Air and fat is more radiolucent than bone and metal. So again, these are relative terms. What I mean by it is easier for X-rays to penetrate this tissue, if we think about all these particles moving through the air, it's going to be a lot easier for X-rays to go through air than it is for them to go through metal. So we won't see a lot of air. We'll see it show up as black because those X-rays went through so fast that no color showed up. Versus something like metal, where that kind of blocked those X-rays from penetrating all the way through the metal, it'll show up really bright white. Everything else is a little bit in between, but when we look at X-rays, we're able to kind of determine what tissues are what based off of those shades of gray. So this is a really good example. This is a chest X-ray. We can look at a lot of different things on here. So first thing that kind of stands out, other than the knife going through their chest, is all the really black color throughout their chest. All of that's air within the lungs. So all that black stuff. Everything that's kind of white throughout there is blood vessels, helping to give blood supply to the lungs. And everything that's white through here is bone. So these are radiopaque because bone is a little bit more white than the lungs, which are filled with air. Right in the middle is the mediastinum, which is just a big sac that contains the heart. So this is our heart shadow, and we know that our heart is more so on that left side, so we can see it more so on the left side of the chest. How do we know this is our left? Generally, X-rays are taken and viewed as if you're looking at the patient. So again, this is patient's right, patient's left. And if we weren't sure and we didn't care, or weren't sure based on that, we could look at the marker. So this is the patient's left side. They have a couple of tubing artifacts. This is more so probably part of an EKG clip on either side. So these are metal. They have their necklace still on, which is metal, and of course that pesky knife going through their chest, which is also metal. On either side here we also have their diaphragms, which appear a little bit more radio opaque, but more so because there's a lot of overlapping structures here from the bone and from the organs that are sitting right underneath them. Shielding. Gonadal shielding practices have been supported for decades, but there is some research that says that it can negatively affect the exam efficacy. So the licensing board for rad techs does endorse this position. So a lot of the times you won't see shielding anymore, because if it's affecting the quality of the film, then the idea is that it's going to make it so that you have to retake it, and you're just exposing the patient to even more radiation. So what's worse, exposing sensitive tissues to radiation once or twice? So that's kind of the gist behind why shielding isn't really utilized much anymore. So this is the beginning of how we're going to position the patient and place the anatomy on the imaging receptor. So we often refer to this guy here as the bucky, or the imaging receptor. The imaging plate is within it, and that's what's going to capture the actual image. You can see the crosshairs here on the patient. Right in the center of that is the central ray. So that's where we're going to kind of send the most of that radiation, although it's going to come out as a beam and kind of diverge here. You'll get more into that with physics. But the most important thing is that we want to position the anatomy so that whatever we're trying to image, the center of that body part is going to be right in the middle of that central ray. So if we were going to do a chest x-ray, we'd want the middle of the chest, the central ray, to be right at the middle of the chest. If we want to do a neck x-ray, we're going to have it right in the middle of the neck, etc. So when we look at this, we're looking right at the middle of the spine, so this is more of a kind of thoracolumbar x-ray. We have a little bit of the abdomen here, but more so we're kind of right in the middle of that spine. What also we should note is that whatever part we're trying to image should be placed as close as possible to the imaging receptor to avoid magnification. There are certain circumstances in which magnification is good. We want magnification, but most of the time it's bad. This is another thing that you'll talk a lot about in your physics classes. But basically, the further away we are, the body part is from that imaging receptor, the more magnification we're going to have. So if this patient stepped closer to the X-ray unit, further away from the imaging receptor, the more magnified she would be. The same principle works. So if we're trying to set her up for a chest X-ray, if we think about the heart's location, the heart is more anterior than it is posterior. It's closer to the front of your chest than the back of your spine. So if we're trying to take a really good picture of the chest, we actually don't want her to be A to P. The best way we can do it is P to A. So she's currently standing A to P because those X-rays would travel through her anterior and go to the posterior part of her body. But if we spin her around and have her face the imaging receptor, then she's standing P to A, posterior to anterior. Then her heart is as close as possible to that imaging receptor and will be less magnified than if she were to be in this position. So that'll be important. Why wouldn't we want the heart to look magnified? It would be a little concerning to the radiologist if they thought the heart was enlarged when it actually wasn't. So this will help to prevent diagnoses of things like cardiomegaly, an enlarged heart, which could be a sign of something more serious. So the central ray is our principal beam of rays, where that radiation is going to be targeted at. So it'll be centered to the anatomy of interest, and generally centered to the imaging receptor. Sometimes we'll have a tube tilt, so it can be sat at an angle. Generally, in this case, and in those cases, it's because there's other structures that are superimposed. So when we're doing an X-ray of the front of the neck, we'll do a tube tilt that's facing upward or cranially because we want to get underneath the chin, the mandible, the jaw. All of that stuff is kind of in the way of seeing the upper part of the neck. Or if we're trying to go through a curved structure like the sacrum or coccyx, we'll have to accommodate that by using a tube tilt, or going through angled joints like the knee. Something you'll hear me say a lot is the SID, the source to image receptor distance. This will be the distance from the anode focal spot, which is inside the X-ray tube, to the imaging receptor, the IR. So basically, the distance from the tube to the imaging receptor. It will affect the magnification of the anatomy. Every setup has a pretty standard SID that you'll use. If you're a flashcard person, you may want to use flashcards for that concept to kind of get down what those general procedures are for each setup. It'll also affect the resolution of the image. If you're too far away or too close, it could affect how good the picture looks. And it can also affect the patient dose. If you have the tube that's way too close to the patient, they're going to be given much more radiation. So the greater the SID, so the further away from the patient, the less magnification there is, the better resolution there is. The common SIDs are 40 inches and 72 inches. When you're in the practice lab, in Academic 1, it'll be in inches, but when you're in the lab where you're going to be doing your competencies, it's in centimeters. So make sure that you learn both. 102 centimeters versus 183 centimeters. We can also talk about the source to skin distance. This isn't something that you'll have to memorize as far as each setup has a specific one, but it is important to note that it will affect the dose of the patient. Like I was kind of talking about before, the smaller the SSD, the larger the dose to the patient, because the closer you bring those x-rays to the patient, the more radiation they're getting. So it's important to remember the general guidelines. So it should be never less than 12 inches, and it should not be less than 15 inches. So like never 12, and should not be less than 15. Sometimes you can be a little bit in the middle, but there are pretty much no setups that you're going to have that are within that distance. Like I said, it's usually 40 inches and 72 inches. Depending on the thickness of the patient and their body habitus, it'll be a little bit less than that because it's just the source to the skin. You've heard me reference collimation as well. This is kind of cropping the light that we see that surrounds the patient. So when we're looking at this, all of this light is what's going to be exposed on the patient. So this room's really bright, but we could usually see where that light is coming outside of the patient as well. And we won't need a lot of air to be exposed to x-rays because the larger the collimation, the less the resolution is going to be. So if we think about like when we're taking a picture on a camera, we might want to crop it a little bit or zoom in a little bit so that it looks a little bit more focused in one area. So we want to focus that light to the anatomy that we're trying to capture, because the larger the collimation, the more the patient dose as well. We don't need a lot of soft tissue in certain areas to be imaged. We certainly don't need all the light to be exposed around her either. So there will be a specific collimation per radiographic procedure, per setup. So we want to restrict it to the anatomy of interest to reduce radiation exposure to the patient, which reduces scatter radiation, which she'll talk a lot about more in those physics classes, which will improve image quality. The collimators are made from lead. They're attached to the tube housing and they're placed between the tube and the patient. you'll see them as dials on the X-ray units that we can see externally on the X-ray unit. So it's really important to make sure that you have that restricted to your anatomy of interest, because it violates your code of ethics via your licensing board to leave the collimator open wider than the required radiation field, because we're exposing the patient to more radiation, which could make their risk of cancer higher. Sometimes when we're using digital units, people will shutter versus using collimation, which means that they cropped the image to get rid of all of the unnecessarily exposed imaging or body parts. However, that's not going to help the patient not be exposed to more radiation. You're just kind of cropping it after the fact. So you can use it when you need to eliminate unexposed areas of an image, but it should not be used to hide poor collimation or in the absence of collimation, because again, the patient is still going to be exposed to more radiation via that scatter radiation. So here's an example of somebody who wasn't collimated properly. So this is a larger patient. We don't need to see a lot of their abdomen here because we are taking an X-ray of their lumbar spine. So note that the lumbar spine is front and center in the middle of the image. That's how we know it's definitely a lumbar spine X-ray, because that's where we put our central ray. However, you can't see really crisp boundaries of all of these vertebrae because of that decreased resolution from the lack of collimation. They also weren't gowned properly because they still have an underwire bra on. So we didn't need to see a lot of this tissue here, and we didn't need to see a lot of this abdomen. But you can see once they collimated properly, we have a lot more resolution, and we can see a lot more of the boundaries of those vertebrae. Anytime you take an image, you'll also be using a marker. Generally, it'll have your initials here at the bottom to show that you were the person that took the image. And there'll be left markers and right markers. Sometimes you'll use specific ones that have beads in them to show if the patient was upright or not. Those are called Mitchell markers. It's important that you always use one so that the radiologist knows what side of the patient they're looking at. Sometimes, although we generally tend to assume which region we're looking at based on how the patient would look if they're looking at us, sometimes images can be flipped unnecessarily or accidentally, or sometimes it looks like, for example, in the chest, there can be genetic abnormalities where the heart's actually on the right side of the body, and if you forgot to put a marker on it, they might think that you flipped the image rather than the patient having this congenital abnormality. So it's important to always make sure that you have a marker on. Markers should never obscure anatomy, so they should always be put in kind of a blank space, not in a space where you're covering like an apex of a lung or another organ or a bone. Always outside or on the edge of the exposure field. Like I just said, we typically display the radiographs as if we're facing the patient. Patient is in anatomical position as if the patient was in anatomical position. Patient's left is on the viewer's right, and vice versa. Patient will always be in anatomical position based on your procedure that you'll be performing, but that's how we'll talk about the imaging when we use those anatomical terms that we talked about earlier. So this is an example of somebody putting the marker in a correct space. So we do have some air that's on the outside of the patient's soft tissue here, so they put a right-sided marker, and there are some markers that also just say which side, especially if you're using digital. So they wrote that this was the right side and that the patient was standing. Other ways that we can determine if something is left or right, for clues, if we assume that the patient's anatomy is perfect textbook anatomy. There's a stomach air bubble up here, and the stomach is on the left side, so we know this is the left. We can also see the liver shadow here, and we know the liver's in the right upper quadrant, so that must be the right side. So those are some helpful things in the abdomen that kind of tip us off as well. Same thing in the chest. We don't have a marker in this patient, but assuming that their anatomy is perfect, this is the heart, and the heart is more so on that left side. So we can assume that we're looking at an image of the patient as if they're looking at us. So this is the patient's right, this is patient's left. And again, that stomach air bubble is there, which is also on the left side. So we saw those earlier, but just a reminder of those anatomical positions. And we talked about this as well. All radiographs will also have patient identifiers on them. Each institution will be different, so you'll have to check your protocol based on wherever you're working at. But each one should include the date of the procedure, the patient's name or ID number, right or left marker, and the institution name. So no matter where they go, they'll always know what date it was taken, what side of the body it was, and where it was taken. All right, go ahead and move on to the last PowerPoint for this week, the chest imaging.